Good morning, all. I am Dr. Nagalingam, Associate Professor, Department of Anaesthesiology from Lakshmi Narayana Medical College, Pondicherry. Today, we will discuss about drugs used in regional anesthesia. Local anesthetics are the most common drugs used in regional anesthesia. Local anesthetics drugs, which used upon topical application, local injection, causes reversible loss of sensory perception, especially of pain in a restricted area of body. They block generation and conduction of nerve impulses at any part of the nerve with which they come in contact without any structural damage. It's a temporary blockade. The order of blockade is autonomic, more than that sensory, then after that somatic motor nerves will be blocked. They are used to provide analgesia and anesthesia during surgeries and non-surgical procedures. Acute and chronic pain management to reduce perioperative stress, to improve perioperative outcome, and to treat dysarrhythmias. This is the neuron. This is a fundamental unit of nerve cell. Everybody will be well aware of this neuron. Mostly in first year itself, you will read very well read about the neurons, which consists of dendrites, cell nucleus, cell body, nerve fiber, myelin, neuruloma, and presynaptic terminal. Whenever the nerve triggers, the impulses will pass. Everybody will be aware in the physiology session. The resting membrane potential is -60 to -90 millivolt, relatively impermeable to sodium ions, selectively permeable to potassium ions. This is the normal physiology. But whenever the sodium potassium pump is active, energy dependent, consistent extrusion of sodium from within the cell in exchange for the next uptake of potassium with ATP. During action potential, nerve membrane transiently switches its higher permeability from potassium to sodium, negative to positive action potential. This is the action potential. Whenever you trigger the nerve, the action potential passes from one nerve fiber to another nerve fiber. Through this process only. Initially, the depolarization will happen. After that, repolarization will happen. Then it will go into the hyperpolarization resting state. Here you can see this is the way the current passes through. Initially, because of that depolarization, it will increase the sodium permeability and the sodium entry occurs towards inward current and potassium efflux outward current happens. Here you can see clearly about the nerve sheath. Everywhere the nerve conduction, this is why the nerve conduction happens through the nodes of Ranvier. Here is the transverse section of the peripheral nerve. It is showing epineurium, endoneurium, and perineurium. Non-myelinated fibers are enclosed in bundles 5 to 10 axons by a chain of squam cells that tightly embrace each axon, but one layer of membrane. Here is again one more cross section of typical peripheral nerve. The epineurium consists of collagen fibers which oriented along the long axis of the nerve. Here you can see A fiber, how it looks like. C fiber, the myelin sheath, squam cell, and how the conduction happens, everything you can see here. The classification of peripheral nerve fibers according to anatomy, physiology, and function. It's usually classified into A, B, C. A fibers again subclassified into alpha, beta, gamma, delta. Alpha fibers mostly used for motor function. It is afferent to muscles. The location is afferent to muscles. Beta fibers used for tactile proprioception. Gamma fiber used for muscle tones. Delta fibers for afferent sensory nerves, pain, cold, temperature, and touch. It modulates these kind of functions. B fibers mainly they're located in preganglionic sympathetic areas and it organizes the various autonomic functions. C fibers also useful in various autonomic functions. It's mainly placed in postganglionic sympathetic fibers and afferent sensory fibers. Nerves in both the CNS and PNS are differentiated by presence or absence of myelin sheath. Myelinated nerve fibers are surrounded by span cells in the PNS and by oligodendrocytes in the CNS. That is the most common differentiation between the central nervous system and peripheral nervous system. If myelin sheath is there, that is called peripheral nervous system. If it's surrounded by oligodendrocytes, that is called central nervous system. Here we can see the myelin around one myelinated axon and one how it goes. The cross section also it shows myelinated sheath and unmyelinated sheath both it's shown in the one figure. Here one axon in the centrally placed that is called myelinated sheath. Unmyelinated sheath it's not covered properly and multiple axons are there. Then we'll see about what are the ways we can give the local anesthesia, regional anesthesia, whether it may be injectable form or surface form. Injectable local anesthetics are low potency, short duration. That is called procaine. Then again classified into intermediate potency and duration. Those are all the drugs called mepiacaine, prilocaine, chlorprocaine, lidocaine. High potency and long duration drugs are tetracaine, bupivacaine, edidocaine, and ropivacaine. Here already we discussed low potency, intermediate, and high potency. Those drugs relative contraction blocking potency it is showing. It depends upon pKa and hydrophobicity. Surface local anesthetics. Again, it's classified into soluble and insoluble. Soluble drugs are cocaine, lidocaine, tetracaine, benoxynate. Insoluble local anesthetics are benzocaine, butyl amino benzoate, oxythiazines. Here we can see the molecular structure of the local anesthetics. You can see both structure of the two local anesthetics. The one is aminoamide lidocaine and the amino ester procaine. In both drugs, hydrophobic aromatic group is joined by a more hydrophobic base, the tertiary amine, by an intermediate amide or ester bond. For example, lidocaine also you can see, procaine also you can see. Ester linked local anesthetics. These are all less intense and less stable local anesthetics. Relaxed for shorter duration. Increased risk of hypersensitivity is there and rarely used for infiltration and nerve blocks. Used topically on mucous membranes. Amide linked local anesthetics are most commonly used in day-to-day anesthesia clinical practice because it produces more intense and longer lasting anesthesia. It binds to alpha-1 acid glycoprotein in plasma, not hydrolyzed by plasma esterase. Rarely cause hypersensitivity reaction. There is no cross sensitivity with ester-linked local anesthetics. Here is a fraction of local anesthetics in the protonated cationic form of an aqueous solution of physiologic pH as a function of pKa of the drug. Lidocaine, the drug is the lowest pKa and the smallest fraction of molecule is protonated. Largest in the neutral form, vice versa is for chlorprocaine. The local anesthetics with highest pKa, individual drug molecules become protonated and deprotonated in thousands of seconds in the solution. If you classify it into ester-linked and amide linked, the drugs from ester-linked local anesthetics are cocaine, procaine, chlorprocaine, tetracaine, benzocaine. If you see amide linked local anesthetics are lidocaine, bupivacaine, debucaine, brilocaine, and ropivacaine. This is the most important aspect, how this drugs works, the mechanism of action. The local anesthetics are used to block nerves in peripheral nervous system and central nervous system. The flow of ions responsible for action potentials and is mediated by a variety of channels and pumps. The most importantly, voltage-gated sodium channels. Local anesthetics bind to intracellular portion of voltage-gated sodium channels in a tonic blockade. This refers to reduction in the number of sodium channels for a given drug concentration present in the open state at equilibrium. There is a repetitive stimulation of the sodium channels. Then it will shift in the steady state equilibrium. Channels being blocked at the same drug concentration, it's the user-dependent blockade. Here you can see how it's working. Whenever the resting state of nerve fiber is there, whenever it's activated, it's because of the local anesthetics. It will bind to the sodium potassium channel pump and it will prevent the opening of the sodium channels. So it will block the action potential. Each voltage gated sodium channel is a complex made up of one principal alpha subunit and one or more auxiliary beta subunit. Alpha subunit is a single polypeptide transmembrane protein that contains most of the key components of the channel function. They include 4 homologous alpha helical domains that from channel pore and control ion selectivity, voltage sensing regions that regulate gating functions and inactivation, phosphorylation sites for modulation by protein kinase. Beta subunits are short polypeptide proteins with a single transmembrane domain. They are linked to alpha subunits by either no covalent or disulfide bonds. Here you can see the things which I have explained. It's clearly demonstrated in the figure. Slow or fast inactivation refers to the duration of which the channel remains refractory to repeat depolarization before resetting to the closed state. Fast inactivation completes within a millisecond and is sensitive to the action of local anesthetics. It is mediated by a short mobile intracellular polypeptide loop connecting domains D3 and D4 that closes the channel from inside the cell through a hinge lid mechanism. Slow activation lasting seconds to minutes is distant from fast activation. It is resistant to the action of local anesthetics. Local anesthetics block peripheral nerves by disrupting the transmission of action potential along nerve fibers. To get to its site of action, principally the voltage-gated sodium channels, local anesthetics have to reach the targeted nerve membrane. The degree of nerve blockade depends upon the local anesthetic concentration and volume. The minimal concentration is necessary to effect complete nerve blockade. It reflects the potency of the local anesthetics. Intrinsic conduction properties of nerve fibers depends upon drug's binding affinity to the ion channels, degree of drug saturation necessary to halt the transmission of action potentials. A sufficient volume is needed to suppress the regeneration of nerve impulses over a critical length of nerve fiber. As membrane depolarization from an action potential passively decays with distance along nerve fibers, the presence of local anesthetic decreases the ability of adjacent membrane or successive nodes of Ranvier to regenerate the impulse. Transmission stops once the membrane depolarization falls below the threshold for action potential activation. If the exposure distance is inadequate, action potential can skip over blocked segments and resume nerve conduction. In contrast, exposure over a long segment of nerve to even a relatively low drug concentration can still result in gradual extension of impulse by decremental decay. Local anesthetics and pH. pKa is equal to log 10 Ka, where Ka is equal to acid dissociation concentration. The lower the pK value, the stronger the acid. pKa actives physiological pH at which the drug is in 50% ionized and 50% non-ionized form. Local anesthetics are weak bases and their activity increases by increasing pH. It's because if large amount of a drug is unpolar, it will facilitate its penetration through the cell membrane. Once the drug has penetrated the lipid barrier and reached site of action, it's ionized and the non-ionized form is responsible for local anesthetic activity. Fetal blood is more acidic than maternal blood. At lower pH, La crosses the non-ionized molecules become ionized in the fetal circulation. Ionized molecule, they are more resistant to diffusion back to across the placenta. Drug accumulation in the fetal circulation happens. The process called ion trapping. During fetal distress, higher concentration of these weakly basic drugs can be trapped. Acidosis, such as caused by inflammation of wound, is partly reduces the action of La. This is partly because most of the anesthetic is ionized and therefore unable to cross the cell membrane to reach its cytoplasmic facing of site of action on the sodium channels. What is differential blockade? Local anesthetic block conduction in the following order. First one is small non-myelinated fibers, non-myelinated fibers, large myelinated axons. This differential block can be achieved. Pain sensation is blocked more readily than the other sensory modalities. Small fibers are more sensitive than large nerve fibers. Myelinated fibers are blocked before non-myelinated fibers of the same diameter. The order of blockade is disappearance of temperature sensation, after that proprioception, after that motor function, after that sharp pain, then after that only light touch. This is why people may still feel touch but not pain when using local anesthetics. How much duration it will work? What is the duration of action of these local anesthetic drugs? Duration of action of drug is also related to the length of the intermediate chain joining the aromatic and amide groups. Protein binding, procaine is the only 6% protein bound and has very short duration of action. Bupivacaine is 95% protein bound and have longer duration of action. If you see pharmacodynamics, amino esters hydrolyzed by plasmacholinesterase. Amino amides are degraded by hepatic carboxyl esterase. The tertiary amide on local anesthetics can accept a proton at low affinity that is classified into weak bases. Structure activity relationship and physiochemical properties. Lipophilic hydrophilic balances, hydrogen ion concentration, and lipid solubility. All are important in mechanism of action of local anesthetics. If you see lipid solubility, the ratio with high concentration of the lipid soluble form favors intracellular entry. That leads to cellular membrane restrict passage of the cationic form, but not the lipid soluble form. Proportion of the lipid soluble form can be increased by alkalization of local anesthetic solution and thus accelerate the onset of action. The cationic form is principally responsible for blockade of sodium channels. Lipid solubility of local anesthetics is conferred by the composition of alkyl substitution on the amide and the benzene groups. Lipid solubility is measured by the partition coefficient in a hydrophobic solvent that is called octanol. Compounds with high octanol buffer partition coefficient are more lipid soluble. If you see lipophilic property, the lipophilic property of local anesthetics may act at two levels. The first is at the level of cellular entry, as greater lipid solubility facilitates passage through the lipid membrane barrier. The second is at the level of binding to sodium channels. Pharmacokinetics of local anesthetics. The systemic absorption. The rate and extent of systemic absorption depends upon the site of injection, drug intrinsic pharmacokinetic properties, the addition of vasoactive agents. The vascularity of tissue markedly influences the rate of drug absorption. Deposition of local anesthetics in vessel-rich tissues results in higher peak plasma levels in a shorter period of time. The rate of systemic absorption is greatest with intercostal nerve blocks, caudal blocks, after that epidural injections, after that brachial plexus block, femoral block, and sciatic nerve blocks. This is the one of the most commonly asked MCQ. Which is the rate of absorption is greatest with the intercostal nerve block. There is the most common MCQ usually asked in AIMS, PGI, PG, all PG exams. The same amount of local anesthetics injected would result in unequal peak plasma levels, depends upon the site of the drug delivery. For a given site of injection, the rate of systemic absorption and the peak plasma level are directly proportional to dose of local anesthetic deposited. This relationship is nearly linear and independent of the drug concentration and the speed of injection. The rate of systemic absorption differs with individual local anesthetics. More potent lipid-soluble agents are associated with a slower rate of absorption than less lipid-soluble compounds. Local anesthetic exert direct effects on vascular smooth muscles in a concentration-dependent manner. At low concentration, more potent agents appear to cause more vasoconstriction than less potent agents, thereby decreasing the rate of vascular absorption. At higher concentration, vasodilatory effects seem to predominate for most local anesthetics. Systemic absorption of local anesthetics are rapid distribution throughout the body. The steady state drug concentration in plasma can be readily derived from apparent volume of distribution. Some amount of the drug will be absorbed into the systemic circulation. How much will depends upon the vascularity of the area to which the drug has been applied. The pattern of distribution is largely depends upon organ perfusion, the partition coefficient between the compartments, plasma protein finding. The organs are well perfused, such as heart, the brain, have higher drug concentrations. What is the elimination, route of elimination? It's primarily determined by chemical linkage. Amino esters hydrolyzed by plasmacholine except cocaine. Cocaine hydrolyzed in liver. Ester metabolite excretion is through the renal. Amino amides transformed by hepatic carboxyl esterase and cytokine P450 enzymes. It's a slow process. It's a longer, because of longer half-life, it can accumulate if given in repeated doses of infusion. Severe liver disease may slow the clearance of amino amide local anesthetics. So molecular structure of the cocaine. Here, if you can see the ester linkage. Natural cocaine is a natural alkaloid from erythroxycline coca. Good surface, it's a good surface anesthetic, rapidly absorbed from buccal mucosa. Cocaine causes prominent TNS stimulation. The first local anesthetic rarely used because of the problems of misuse. It is unique in its ability to produce intense vasoconstriction. Its half-life is 30 minutes. Dosage usually as topical 4 to 10%. Maximum dose is 1.5 mg per kg. Only indication for use is ocular anesthesia. However, causes vasoconstriction of conjunctival vessels, sloughing of cornea can happen. Cocaine should never be injected as its protoplasmic poison can lead to tissue necrosis. Here is the molecular structure of procaine. First, it's a first synthetic local anesthetic, popularly declined after the introduction of lidocaine. The only indication for its use in dentistry in patients with proven allergy to amide groups. It's used intraarterially as a part of recognized regimen to treat arteriospasm, which might occur during IV sedation. Forms poorly soluble salt with benzyl penicillin. The slows absorption from its site of action. Rapid onset, rapid offset. It's a neurotoxic, so not used in spinal anesthesia. Chlorprocaine. It's a rapid onset, rapid offset. Recently have seen their use increases in spinal anesthesia. Nowadays it's available in the market. So a lot of people they are using for short spinal surgical procedures. Benzocaine, also known as butylamino benzonate or butamben. Benzocaine mainly used as a topical due to its poor water solubility and because of its low toxicity, it is used in concentration up to 20%. So hydrolyzed rapidly by plasmaesterase to p-aminobenzoic acid, accounting for its low toxicity. Used as lozenges for stomatitis and sore throat. Powder ointment on wounds, ulcerated surfaces, and as suppository for anorectal lesions. It is also known as tetracaine, also known as amitocaine. It's highly lipid soluble and more potent. Equally more toxic due to slow hydrolysis by plasma pseudocholinesterase. Then coming to lidocaine, it's a amide-linked local anesthetic. Lidocaine is the most commonly used local anesthetic in day-to-day anesthesia practice. It's versatile, surface action as well as injectable and available in many forms. It's a rapid onset and lasts for duration of 60 to 75 minutes. Extended for up to 2 hours when solution with epinephrine are used. It's also used popularly as an anti-arrhythmic drugs. Bupivacaine. Bupivacaine also one of the most commonly used drugs in practice as well as in spinal anesthesia and local anesthesia. It's a no topical effect, slow onset and long duration of action. It's provide analgesia without significant motor blockade when used as epidural in lower concentrations. High lipid solubility, high distribution in tissues due to protein binding, so less in blood. It's available in 0.25% and 0.5% solution. It's a cardiotoxic drugs. It causes QT prolongation leading to BT and cardiac depression. So not used in IV regional anesthesia. Ropivacaine. It's a newer bupivacaine. It is also most commonly used. It's only available as pure as S isomer. It blocks A delta and C fibers more completely than alpha A beta fibers. Less motor blockade than bupivacaine. It's otherwise equipotent anesthesia but less cardiotoxic. Epidural ropivacaine is used in postoperative and labor pain. Mepivacaine. It possesses the least vasodilating effect, metabolized in the liver and has T-off of 120 minutes. Its main indication is when local anesthetic without vasoconstriction is needed. 3% plain is more effective than lignocaine. It's rapid onset but slightly shorter duration. Prilocaine. Prilocaine is a very potent local anesthetic and is less toxic than lignocaine. It produces vasodilatation and then lignocaine. Rate of clearance is higher than other amide types, suggesting extrahepatic metabolism with relatively low blood concentration. Its metabolite O-toluidine lead to methemoglobinemia. This is also again one more MCQ which can be repeatedly asked which local anesthetic causes methemoglobinemia. Then we'll see what is all the uses of local anesthetics. Where all this local anesthetic can be used. Can be used in local anesthesia, topical anesthesia, local infiltration, peripheral nerve blocks, intravenous regional anesthesia, spinal anesthesia, epidural anesthesia, and tumescent anesthesia. Topical anesthesia, we will see on topical anesthesia. Local anesthesia placed on mucous membrane or skin. Cocaine most commonly used for rhinolaryngoscopic procedures due to vasoconstricting effect. LOX oxymetazoline combination is equally effective. Nebulized LOX used for surface analgesia for fiber optic laryngoscopy and bronchoscopy. Rapid absorption of local anesthetic from these mucosal sites and blood concentration are achieved or similar to IV route. Emla cream. This cream is most commonly used in pediatrics. Ectotic mixture of local anesthetics 2.5% lignocaine plus 2.5% pilocaine. It diffuses through intact skin to block neuronal transmission from dermal receptors. Dose 1 to 2 gram per 10 centimeter area under occlusive dressings. It's used for skin graft harvesting, IV cannulation, cauterizing genital warts, and circumcision. To be applied 45 to 60 minutes prior to the procedure. It's low frequency ultrasound speeds the onset. Side effects like pruritus, edema, erythema, rash. It may cause methemoglobinemia in children less than 3 months and patients oxidizing drugs like sulfonamides, paracetamol, phenytoin, and NTG. Local infiltration. Extravascular placement of anesthetic in the area to be anesthetized. Choice of agent depends upon the desired duration. Lignocaine is the most commonly used agent in local infiltration. Duration may significantly increased by adding 1:2 lakh epinephrine. Peripheral nerve blocks. Local anesthetics injected in the vicinity of peripheral nerve or fluxes. Local anesthesia diffuses from mantle to core across a concentration gradient. Proximal anatomic structures are first to be anesthetized and first to regain sensation. Sequence of onset and recovery in a mixed nerve depends more on the anatomic location of the fibers. Dose required is lesser if USG guided blocks are used, as the local anesthesia is placed in the immediate perineural area. Long-acting amide local anesthetics like bupivacaine and ropivacaine are preferred as they provide analgesia for up to 12 hours. Ropivacaine may prove to be a better choice because of its shorter duration of motor blockade and less cardiovascular side effects. IV regional anesthesia, there is intravenous regional anesthesia. Here, local anesthetics injected through IV in a tourniquet occluded limb. Local anesthesia diffuses from vascular bed to non-vascular tissues like axons, nerves, and dinks, leading to conduction blockade. Occluding tourniquet is gradually released. Pilocaine attains the lowest blood concentration as compared to lignocaine when administered in equal doses. Dose of lignocaine is 3 mg per kg, or is 40 ml of 0.5% solution. Chloroprocaine, bupivacaine, and ropivacaine not recommended for IVAA RA because of cardiac toxicity. In spinal anesthesia. Local anesthetics injection in the lumbar subarachnoid space. The site of action is preganglionic fibers as they leave the spinal cord in the anterior ramp. Differential zones of autonomic sensory motor blockade can happen. Total dose of local anesthetic more important than the volume or concentration. Hyperbaric solution produce more dense block. Duration depends mainly on systemic absorption for both ester amide local anesthetic. The side effects are hypotension, bradycardia, cardiac arrest, respiratory depression, and apnea. Epidural anesthesia. Local anesthesia placed in epidural sacral caudal space. Local anesthesia diffuses in paravertebral area and across the dura to act on nerve roots and spinal cord. It delayed on the onset compared to spinal anesthesia. The zone of differential motor blockade extends 4 segments below the sensory level. Long-acting amide local anesthetics in lower concentration may be used for postoperative analgesia and labor analgesia without producing significant motor paralysis. Then we will see something about tumescent anesthesia. It is a technique of local anesthesia most commonly used by plastic surgeons during liposuction procedures. Involves a subcutaneous injection of larger volumes of dilute local anesthetics in combination with epinephrine. Total dose of lignocaine ranging from 35 to 55 mg per kg produces safe plasma concentration which can peak more than 8 to 12 hours after infusion. Despite these seemingly huge doses, good outcomes have been reported in several case series. Other uses. For analgesia purpose, lidocaine is used as a continuous infusion to maintain a plasma concentration 1 to 2 microgram per ml. It's effective in postoperative pain and stump pain. IV lignocaine in the perioperative period used as a cough suppressant. Anti-arrhythmic IV lignocaine used in a dose of 1.5 mg per kg. Anti-epileptic suppression of grand mal seizures and bronchodilation. Here, this is a chart showing various drugs and how much concentration and how much volume and total dose and varicity. Everything here explained clearly. Usual doses of local anesthetics for spinal anesthesia. Most commonly, we are using bupivacaine 0.5%, 0.5 to 1 mg per kg. The duration of action is 65 to 75 minutes. Here you can see infants to adolescent. The difference you can see, the commonly used drugs are bupivacaine and ropivacaine, 0.5%. Its dose is 0.4 mg per kg for 5 to 15 kg kids, infants. The adjuvants most commonly used are clonidine, fentanyl, morphine. The dosage explained here clearly. If you add additives, the duration of action definitely it will increase. Drugs with epinephrine available in the market, most commonly we are practicing in lignocaine with adrenaline. The concentration is 1 to 2%. Usual volume is 15 to 30 ml. Maximum dose with epinephrine is 500 mg. Without epinephrine is 350 mg. Various preparations intended for topical anesthesia. Here you can see cream, ointments, aerosol available. Each and every drug available as a different combinations. But in practice, most commonly we are using lignocaine jellies, suppositories, Emla cream we are using commonly. Coming to toxicity of local anesthetics. The most common toxicity is allergic reactions. Less than 1% of drugs, allergic drug reactions due to local anesthesia are due to allergic reactions. More common with the esters as compared to amides due to formation of PABA related compounds. When using amides, the allergy is mostly due methyl paraben, which is added as preservative. Cross-sensitivity occurs between esters but not wet agents of different classes. Allergy testing, intradermal testing by using preservative-free preparations. Systemic toxicity. Due to higher plasma concentration of local anesthetics, accidental IV injection, tissue absorption depends upon dose administered, vascularity of tissue, use of epinephrine, and lipid solubility of the drugs. Acute toxicity. The risk of seizures and cardiovascular collapse is increased by cold temperature, metabolic or respiratory acidosis, and hypoxia. Acute toxicity with most drugs, CNS toxicity precedes the cardiac toxicity, providing a warning of impending disaster. It's a key response. It should be maintain the oxygenation and normal CO2. With the bupivacaine, CNS toxicity rapidly progresses to cardiovascular collapse. Pregnancy enhances the risk of cardiac toxicity. The CNS toxicity or toxic concentration for lignocaine is 5 to 10 microgram per ml, bupivacaine 4 to 4.5 to 5.5 microgram per ml. The rate of increase of serum concentration is more important than the absolute concentration reached. Symptoms of CNS toxicity are numbness of tongue, circumoral tissues, restlessness, vertigo, tinnitus, muscle twitching, and tonic-clonic seizures. CNS depression with hypotension and apnea can lead to coma and arrest. The factors reducing seizure threshold are PaCO2 maintenance, hyperkalemia, raised serotonin, and mexiletine treatment. How will you treat this patient? Immediately, you should intubate the patient, put on controlled mechanical ventilation, and hyperventilation you should do. Midazolam can be used. Midazolam 0.05 mg per kg IV and thiopentone 50 to 100 mg IV can be used. Cardiac toxicity. The most common drug cardiac toxic is bupivacaine, after that ropivacaine, and after that lidocaine. Factor enhancing toxicity of bupivacaine are pregnancy, beta blockers, calcium channel blocker, digoxin, addition of epinephrine, hypoxia, hypercarbia, and acidosis. Effects of bupivacaine isomers on cardiac sodium channels are dextrobupivacaine has faster onset of action than levobupivacaine, has greater affinity for cardiac sodium channels, has lower offset time. The clinical features are hypotension, chest pain, palpitation, dyspnea, diaphoresis, lightheadedness, wide QRS complexes, wide PR interval, VPC, ventricular premature contraction, ventricular tachycardia, supraventricular tachycardia, and AV heart block. The treatment is supportive and CPR as under standard protocols, breathalium 20 mg per kg, and lipid rescues. What is lipid rescues? Use of IV lipid emulsion to treat severe local anesthetic toxicity. Pioneered by Dr. Guy Weinberg in 1998. The mechanism of action is lipid sink theory. Exogenous lipids provide an alternate source for binding of lipid-soluble local anesthetics. Bupivacaine molecules preferentially segregate from plasma to lipid in a 1:12 ratio. It also reacts significantly with tissue bupivacaine. Lipid act as a substrate for cellular energy production, may act on nitric oxide pathways. Dosage. It is advisable to initiate the lipid infusion once the conventional treatment modalities have begun. IV bolus intralipid 20%, 1.5 ml per kg over 1 minute. IV infusion at 0.25 ml per kg per minute. Bolus injection at 5-minute interval if circulation is not restored. Increased infusion to 0.5 ml per kg per minute after 5 minutes if circulation is not restored. The side effects of thrombophlebitis, pulmonary hypertension, infection, warfarin resistance, allergic reactions, ICP after head injury, fat emboli, seizures in children. Methemoglobinemia, most commonly with prilocaine, benzocaine, lignocaine, and others also responsible. Risk factors are neonates, patient on oxidizing drugs. Central cyanosis at methemoglobin more than 15% can happen. 10% clinical anoxia, 60% it will show stupor, coma, and death. Documented with benzocaine, prilocaine. Treated with benzyl blue, methylene blue, 1 to 2 mg per kg over 5 minutes. Faster administration may exacerbate methemoglobinemia. Drug interactions. Esters are metabolized by pseudocholinesterase, compete with succinylcholine for metabolism, so when given together, each lasts longer. Metabolism slowed by administration of anticholinesterase. Local anesthetic toxicities are additive. Divide lignocaine dose by 4 to convert to bupivacaine equivalents. keep lignocaine by 4 plus bupivacaine less than 3 mg per kg. Thank you all. I hope everybody now understood about what are all the drugs used for local anesthesia. Drugs used in regional anesthesia. Everybody is aware of this session. Thank you all. Thank you.